Do you wonder if you're the best version of yourself? This is the question we seek to answer in this podcast. We reveal information that helps you recover your health and become resilient. Modern life makes us fragile. Our diet, lifestyle, and environment set us up for failure. We do not accept this. We seek optimization. We strive to become dynamic. Hey, what's going on? Dr. Chris here, and today I want to talk about precision in diagnosis and how that can greatly impact your experience, and also imaging, how you can't just rely on an image to properly diagnose what's going on. You have to correlate the findings in the image to what you find clinically. So I'm going to talk about 3 different examples, 3 case studies, and how different the experiences were for each of them and what could have gone wrong. So they're all came to me for different things, 2 for foot pain actually, and 1 for knee pain and hip pain. And all 3 of them turned out to be mostly back pain. So in other words, sciatica. So let me just give you a quick overview. I'm sure you've heard of sciatica. That's when something is compressing the sciatic nerve and causes pain down a leg. It usually happens in the spine. It can happen in other places too, but L4, L5, S1 area is the most common. That's your lower lumbar spine. It's a natural hinge of the body. So just the shape of the spine, it tends to get irritated first. And then depending on where in the leg you're feeling it, what type of symptoms you're having, we can kind of tell, and how much compression, we can generally tell where it's coming from. We have dermatomes and myotomes. A dermatome is an area in the leg that's, you can Google this, dermatomes of the leg or dermatomes of the foot, and that's an area that is innervated by certain levels. So, for example, we say L3 to the knee, L4 to the floor, so that's just kind of a quick way to memorize. The L3 nerve root can affect the knee, the L4 can affect the foot, and so on. And then there's corresponding reflexes, so you can get a diminished reflex on one side. So say L4 was affected, you would expect a diminished patellar reflex on that side. So we can test those things. We can test dermatomes, like strength tests for dermatomes, and we can test reflexes for the levels. And we also can do things. We can move the spine and see if that makes a change, or makes it better or worse. If that makes it better or worse, there's a chance that that's where it's coming from. So it's a whole cluster of findings that we have to look at. So the first patient came to me. She was having some foot pain. She had, I believe, an image of the foot that was unremarkable. So that's your first sign right there. Okay, maybe it's not really foot pain. And then I did an evaluation. She had been dealing with it for about 3 months and couldn't figure it out. Every time she walked, it would get worse. So she assumed it had something to do with walking and weight bearing, which makes sense. And it turned out when she leaned backwards, like doing the limbo, that would provoke the pain. If she bent forward, that would reduce the pain. This is known as stenosis. So you bend forward, it opens the space between the vertebrae. If you lean back, it closes the space between the vertebrae. So if that vertebrae is a little bit compromised, or in her case, she had a stiff hip flexor, because hip flexor is attached to the lumbar spine, and when you walk, the leg has to extend behind you, which takes all the slack out of the hip flexor, and that can kind of pull the lumbar vertebrae into extension. You can kind of see this, and an easy way to test it is if someone's laying on their stomach on a table and you stretch their quad, does that reproduce the pain? Because that basically pulls them into a little bit of extension of the spine. Or you can elevate the knee and stretch it again, so now you're targeting a little more all the hip flexors. So, clear sign is, ouch, that hurts my back. If they contract the core, does it go away? Yes, because they put the spine neutral. So that's a really clear signal. Anyways, so that was her case. So she was, only been dealing with it for 3 months. I told her what things to avoid doing temporarily, to let it cool down. Gave her a stretch for hip flexor and some exercises for the spine, for the muscles that attach from one spine to the next. They're called the paraspinal muscles. That helps fight the pull of the anterior pull of the hip flexors. She came in the next visit. She's like, oh my God, it's gone. The pain is gone. In just one session, just an evaluation. So that's a good story right there. The second one is actually a family member of mine. So he's been hobbling around for about 3 years with horrible foot pain, and he's done blood work. His uric acid was a little bit high, so they said, oh, that's gout. He did the cherry juice, he tried alfalfa sprouts, tried a bunch of things a little more holistic, and none of it seemed to help, still hobbling around. Got an image of his foot, found a mild arthritis. And so he came to see me finally after much coercion. And it was a very similar story to the first one. All right, so I have him move his spine. Okay, it's a little bit better. When you side bend to the non-painful side, it seems to get better. When you side bend towards the painful side, it gets worse. Is that a weight-bearing issue? No. It's closure of the spine. So if you're staying there and say the right foot is affected, if you side bend to the right, you're closing the right side of the spine and opening the left. So that was reliably reproducing his pain. And I said, look, we haven't changed anything with your foot or ankle, so how could that make any difference? If just leaning to your left, which opens that side of the spine, makes it go away, that we didn't change your ankle. And then, of course, I did test the ankle, and nothing was provocative, nothing was tender to the touch. Reflexes were diminished on the side, sort of standard case. So I gave him kind of a similar set of exercises as the first patient, and now he's been dealing with it for a couple weeks. He's still in a fair amount of pain. He's getting better, but still in a fair amount of pain. His deal is that he weighed 3 years. So the longer you irritate a nerve, the longer you get to keep it, the longer the rehab is. So that's patient number 2. Patient number 3 came in initially for hip pain. Then it moved into his knee, and he had an image of his knee. Now, I've worked on a lot of arthritic knees. This definitely looks like an arthritic knee. You can hear it kind of cracking around in there. It has a different appearance to the other knee. It just looks bigger. That's a typical sign of an arthritic knee. The x-rays of the knee confirmed severe arthritis, quote-unquote bone-on-bone, which is a phrase I hate because bone-on-bone indicates to the patient that they have to get surgery. So he's looking at potential knee replacement. But something still wasn't adding up. When I compressed his knee on the table, it didn't hurt. A weight bearing would hurt, but if I had him squeeze his abs, squeeze his glutes, the pain will go away. So that's more suggestive of the spine, because when you squeeze your glutes and abs, the spine opens up and goes into a neutral position, and that would happen very reliably. So with his case, I told him, look, I think this is coming from your spine. I know you have clear images of your knee being severely arthritic, but there's no reason that just doing what we call like a bracing of the core should change your knee pain. So we did work on some stuff for his knee strength and range of motion, because why not? But we also worked on some stabilization of the spine, stretching the hip flexors, sort of the common things. We did some traction, and that all kind of reliably but temporarily reduces pain. So he opted to go get an image of his spine, and sure enough, severe stenosis of the spine. We tried for a little longer. He's been dealing with this for many years. And so he decided, at first they were saying, go get a knee replacement. Well, we talked for a while, and he decided to go and get a spinal decompression, which is where they carve out the foramen, which is the hole where the nerve exits through. That's a decompression surgery. It's an outpatient procedure. So he went for that, and boom, his knee pain was gone, 100% gone. I couldn't reproduce it in standing, couldn't reproduce it bending his knee or anything like that. So 3 different patients, kind of similar stories, diagnoses that got missed, diagnoses that were sort of relied upon imaging for, and with all very different outcomes. So the first one, she came in early. She was staying ahead of it, and she's out of pain in one visit. That's fantastic. Second one, waited for a long time. He's on the right path, but doing all the other things first was doing nothing for him. So he just wasted a lot of his own time and has been dealing with pain for 3 years. You know the credo, do no harm. Well, the third one, now, he could have gone and got his knee replacement. And knee replacement is extremely painful rehab. Could take 6 months, could take years, depending. There's definitely evidence of severe arthritis, and maybe down the road he may need a knee replacement. But put yourself in his position. Had you just gone right for the knee replacement immediately, you would have gone through torturous therapy for 6 months, still have a ton of pain, and then when the knee is like quote unquote healed and good to go, he still has the pain because he never fixed the issue at the back. How angry would you be? Then what would happen next is he would go see his back guy, and then they would suggest that surgery. So he'd be delaying his rehab and just giving him a whole lot of pain that probably is not necessary. So getting it right from the get-go is paramount. You can have a very speedy recovery. You could delay your recovery. Or you could even do the wrong procedure and deal with a lot of wasted time, pain, and frustration. Now, this is just a personal bias, but I think seeing a physio first is not a bad idea, depending on what's going on, obviously. But if it's something orthopedic like this, one of the things that most physical therapists have advantages with is we have time. So this is a problem with our system that most physicians are just super busy, and they don't really have, like I do, like an hour to evaluate somebody and really get a thorough history and really understand the full picture. Some of these physicians see like 50 patients a day, and you tend to kind of categorize by joint. Okay, this morning I got 3 knees, 4 shoulders, 2 hips, and so when you start to think that way, and it kind of makes sense to kind of lump it together, then you put the blinders on and it can get myopic. So it's not a problem with the practitioner, it's a problem with the system. So if you relate to this at all, if you've maybe been down the rabbit hole a bit, gone and seen multiple providers, you still don't have answers, try physical therapy because you might just find the answer there. A ship in harbor is safe, but that's not what ships are meant to do. What does this mean? It means exposing yourself to difficult situations so you become resilient. If you need help building resilience, check out our flagship program called Physiologic Flexibility. This is a 3-month do-it-yourself program that teaches you how to maximize your homeostatic regulators, such as your pH, blood glucose, O2 and CO2 tolerance, and temperature. We give you specific action items through the program with the goal of becoming anti-fragile. If you want to become the inspiration for your friends and family, this is the program for you.